Good evening. It's good to have you. You're watching Your Health Show. My name is Purity Museo. Now, malaria remains a primary cause of childhood illness and death in sub-Saharan Africa. More than 260,000 African children under the age of 5 die from malaria annually. On October 6, 2021, the World Health Organization, WHO, recommended widespread use of RTS malaria vaccine among children in sub-Saharan Africa. The endorsement has been termed as historic breakthrough for science. And what does the recommendation mean in the fight against the deadly disease here in Kenya? Today we talk about malaria prevention. We look at symptoms, complications and preventions, and most importantly we talk about the malaria vaccine, the rollout plan and the Ministry of Health policy on how this vaccine will be administered to children across the country. Our guest is Dr. George Githuka, Head Division of Malaria Control Program here in Kenya. Thank you so much, Dr. for joining us, and it's good to have you this evening.
Thank you for having me.
Reports indicate that it's prevalent in especially sub-Saharan Africa. Maybe we can begin there. Why is it prevalent in the African country? What is this disease, and what are some of the possible causes?
Okay, thank you. I think as you have put it in the introduction, malaria is a disease of still a huge public health concern. It is transmitted by the female Anopheles mosquito. And basically, as you've said, the most prevalent malaria parasites that we have is Plasmodium falciparum. Yeah. This parasite is transmitted by the mosquito from one infected person to another. And unless we can be able to cut that transmission, then it continues spreading. In Kenya, the malaria prevalence right now, according to our malaria indicator survey we did the year 2020, is about 5.6%. However, with a lot of regional variation, right, with the counties around Lake Victoria, what we call the lake endemic counties, 8 of them having the highest prevalence of 19%, meaning almost about one in every 5 people will be having the malaria parasite at any given time. We have also the coast endemic counties. Those are the counties around the Indian Ocean, the Mombasa, Kilifi, Kwale, etc. We have the highland epidemic prone regions, whereby malaria transmission occurs during the rainy seasons, the long rainy seasons. We have 2 rainy seasons in the year in Kenya. The long ones from March, April, May, up to almost June. And the short rains, the ones we are about to experience now from October to early December. Yeah. We have the seasonal transmission areas, the arid and semi-arid, northeastern, northern region, where the transmission occurs when you have heavier than usual rainfalls. And the low risk, like where we are in Nairobi, the central counties, the lower eastern counties, where again the risk or the transmission of malaria is very low. One of the things that contributes to this and why it's high in sub-Saharan Africa, number one is the climate. The mosquito parasite, which is a vector, the mosquito rather, which is a vector for the malaria parasite, thrives in warm climate around water bodies. As I've said, in Kenya, you've seen the counties around Lake Victoria and the counties around the coastal region. Yeah.
You mentioned that the Anopheles mosquito thrives best along those regions. Maybe what are the conditions that, because you talked about during rainy season, and sometimes the low-risk areas will experience high prevalent when it rains, when these areas experience long rains. Maybe what are the, do I call them perfect conditions for the Anopheles mosquito to thrive, or why is it that the malaria is prevalent in these areas?
It's prevalent around the rainy seasons. We call them the peak transmission seasons, particularly because the mosquito lays its eggs in stagnant water, and these eggs hatch into larvae, and the larvae mature into mosquitoes. And for that process to be able to happen, fast enough, or ideally, the weather also needs to be warm so that it can facilitate that environment. So the reason why the peak transmission periods are during the rainy seasons is because of that issue of having pools of water. You find that a lot of areas, there are a lot of containers that have been, plastic containers that have been dumped, like the tires that have been abandoned, basically bodies that are able to hold water, but without flowing. The water also needs to be stagnant so that the eggs are not carried away in the larva. And this is where the mosquito, breeds. This is where it lays eggs and the larva. matures into, the eggs hatch into larvae and the larvae mature into mosquitoes.
Yeah, and does that only happen as far as Anopheles mosquito is concerned? Because they say if you are in Nairobi, the mosquitoes in Nairobi don't transmit malaria. Is it true? That
is all mosquitoes in general. We have many species of mosquito. As we always say, they not only spread malaria, we have mosquitoes that even spread other diseases that we have heard about, like the chikungunya virus, the dengue fever, you know, like what we're having in South America, the Zika virus, you know, the parasites that cause elephantiasis. So generally, mosquitoes tend to breed uniformly, though it may vary species to species. There are some who breed better within urban centers, some better within the rural areas. And an example of an Anopheles mosquito, it's able to breed better outside the urban centers, where, you know, the water is clean and the environment is more open.
Most of the symptoms of malaria are almost the same as those of the pandemic. So how do you distinguish between this person is suffering from malaria and not COVID-19?
A lot of the signs and symptoms are the same. You know, fever, joint aches, headaches, you know, feeling weak. Sometimes you may have some vomiting, amongst others. So what we normally recommend, if you experience any of these symptoms, do not try to self-diagnose. You know, don't walk into a pharmacy or a chemist, you know, with a diagnosis without any, you know, testing and seek treatment. I will insist on going immediately because most of these medical conditions will complicate if you take time to get properly diagnosed. I'll give an example. If you have COVID and you have symptoms and you think it's malaria and you take anti-malarial drugs, then by the time you present to hospital, you might be having severe symptoms of COVID that may be difficult to manage.
What are the possible complications of malaria?
Well, as I said, when you get malaria and it's uncomplicated, it's quite easy to treat. As we recommend an artemisinin combination therapy. In Kenya, we use artemether-lumefantrine, a drug you take for 3 days. And within those 3 days, then you have recovered from malaria. If, however, the malaria progresses to become severe, either due to not seeking treatment on time, maybe not being appropriately diagnosed, sometimes, and rarely happens, where maybe you may be diagnosed, you find that there are many complications. I'll give, for example, of malaria when it occurs in pregnancy, or when it occurs in a pregnant mother, and it remains untreated. It's going to lead to loss of that pregnancy. It's a leading cause of loss of pregnancy, either early in pregnancy, what we may call an abortion, late, what we may call a miscarriage. It may lead to premature delivery of that child, may lead to stillbirth, whereby a baby dies during delivery, or even death of the baby soon after. It's also a leading cause of maternal mortality. When mothers deliver, they lose a bit of blood. The malaria parasite affects our red blood cells that carry oxygen within our bloodstream, and when it is not managed on time, then your blood levels go low. And when these mothers bleed, even what you'd call normal, it's excessive for them and may lead to death. Children less than 5 years are also very vulnerable. They have a very high likelihood of developing severe malaria.
Is it because of the low immunity that they have?
It's because of the low immunity. Sometimes it's because of also, children have challenges when growing up. You might find this child maybe was a bit malnourished. They may have other infectious diseases like worms, for example. So when this child is affected by malaria, and also children tend to present with symptoms that are not typical. You know, a child is not like an adult who tell you, I'm having a headache, I'm feeling this. A child, you might just notice a child is not playing, is feeding poorly. You know, there is a tendency of, if the symptoms are not clear, of the mother waiting to see what happens. So when these children develop severe malaria, then their likelihood of dying is very high. And what I was saying, the likelihood of long-term effects is also very high. When they get cerebral malaria, they get convulsions at that age. They may have convulsions for the rest of their lives. As I said, malaria reduces the level of blood that transports, the red blood cells that transport oxygen to our organs. So if these organs are starved of oxygen, like kidneys, etc., then they may need to those organs failing in a child or even in an adult.
The available interventions that the Minister of Health has been doing just before the World Health Organization did declare that there's now a vaccine for it. Why are we not Is it winning the war, reducing the numbers as per what the ministry is recommending? What are the interventions and challenges accompanying their implementation?
As I said, we've made a lot of progress in the fight against malaria. We have the interventions that we have. Number one, we do recommend people to sleep under insecticide-treated nets, especially the people living where malaria transmission is happening. As a Ministry of Health, you know, with support and collaboration from partners, we normally do distribute nets every 3 years, what we call mass net campaigns. Like, for example, this year we are distributing nets to 27 counties, 15.7 million nets to cover around 25 million people. We also do what we call routine net distribution, again, where malaria, in the counties where malaria transmission occurs, when pregnant mothers come to antenatal clinic, they are given a mosquito net to sleep under it. And when they bring their child the first time for the child welfare clinic, they're also given a mosquito net for the child. So the most widespread intervention that we use and recommend is the use of insecticide-treated bed nets. The other interventions that we use to variable levels are indoor residual spraying, mostly done in the highest burden counties. Like, for example, we do in Migori and Homa Bay counties, whereby we spray insecticides in the house. And they are supposed, you know, to protect the entire households against, you know, mosquitoes coming in and being able to transmit malaria. Other intervention that we recommend is what we are saying, seeking treatment early when you have signs and symptoms of malaria, seeking diagnosis and treatment early. As I said earlier, the mosquito can only transmit the malaria parasite from one infected person to another infected person. So when we have a minimal number of people living, you know, staying with malaria too long, then it reduces the period when a mosquito can be able to transmit malaria from them. We also do larva source management, where we spray malaria breeding sites with insecticides. However, there is no one intervention that is 100% effective of all those that I've been able to mention.
Yeah.
We implement them, they do bring down the burden of malaria. But if, for example, you stop sleeping under a mosquito net, then, you know, the cases start going up again. Yeah. If people delay seeking in treatment, it goes up again.
The interventions that we have in place. And then when we talk about malaria, do we have anything like being immune, like once you're infected, once you will not be able to be infected another time, or it should be a lifestyle, you know, sleeping under treated mosquito nets, spraying your environment, it should be a lifestyle?
Yes, that's exactly correct, is what I was saying. You know, these interventions that we implement, you have to keep on doing them for you to remain protected. You cannot, you know, there is no immunity developed from malaria infection. Yeah. In fact, we say, if you've had a malaria infection, then you should even put more effort to avoid getting another infection soon after. The reason for this is what I was saying. The malaria parasite affects red blood cells. So if you get malaria today and you don't seek treatment on time, your level of blood, your red blood cells go down. Your immunity actually is weakened by this infection against malaria. If we are talking about children, they might even get some level of malnutrition. So your body is already weak. So as your body is trying to recover, if you were to get another bout of infection, then the risk of it becoming severe is even much higher than the first one, because it's already finding somebody who's weak. So we recommend, if you have had even a bout, you should actually be more keen to protect yourself. Yeah. In terms of the interventions we've put, the number of infections they've been able to, infections and deaths they've been able to avert, it's quite a number. As I've said, you don't normally hear, like we used to hear a long time ago, the issues of having outbreaks of malaria being common, especially where we have known malaria to be there. What has also happened is that due to climate change, you know, due to global warming, as is always being said, we are finding areas that normally malaria never used to be transmitted happening. So we are getting new hotspots, we may call, for malaria, and that's why we're experiencing a bit of outbreaks.
Let's talk about the vaccine. It's been termed as a game changer in child health, preventing malaria, especially among the children who are most vulnerable to the disease. What does it mean for, and Kenya was among the 3 countries that were taking part in the pilot program. Let's talk about what this breakthrough means for in the fight against malaria first, then we can talk about the rollout plan by the Minister of Health.
This vaccine, as you said, it was being piloted, or rather it's still being piloted in 3 countries, Ghana, Malawi, and Kenya. In Kenya, it's being piloted in the highest burden counties, the lake, what I call the lake endemic counties. And it's not being implemented, it's not in all the sub-counties. We've also selected a few sub-counties to be able to pilot this. What was the purpose of the pilot? Number one, this vaccine was found to be safe, effective and efficacious, even before the pilot was started. There was already a vaccine that within research settings, it was found to be safe, effective, and efficacious. The reason for the pilot was to be able to determine, one, whether the results that have been found in the lab would be replicated in a population, whether it would have an impact, whether we would have amongst where the vaccine is being implemented, an actual reduction in number of malaria cases, and also a reduction in the number of severe cases, because the vaccine is meant to protect against malaria. And even when you get malaria, it's supposed to protect you against severe malaria. So that was the number one purpose of the pilot. The number two purpose of the pilot was to be able to see whether it is being implemented together with other routine immunizations that are given to children. It's not being given as a parallel. It's being given at 6 months. The first dose of injection is at 6 months when the children are coming for their first vitamin A. The second dose is at 7 months when they're coming in for weighing. The third dose is at 9 months when they're coming in for the measles vaccine. And the fourth dose at 24 months or at 2 years when again they're coming for their vitamin A and also weighing.
So it's very convenient.
It's integrated. So we wanted to know, number one, would it affect other routine immunizations? You know, when you introduce a new vaccine in immunization schedule that was already working, there is fear that it may disrupt it. Mothers might shy away because they don't want the malaria vaccine. They also avoid coming for the other immunization. So it was find out, will it create that amongst, and mothers actually did not, it did not affect the routine immunizations, and the uptake was also very good. And that also showed us how the mothers already perceive that their children are at risk of malaria and they need protection. Actually, the positive uptake of the vaccine. The number three reason why this vaccine was being piloted was to find out, would it affect the health-seeking behavior of their mothers to their children? Would there be a scenario where a mother would say that my child has been vaccinated against malaria? So if they develop fever, if they develop headache, if they develop these symptoms that are similar to malaria, I won't go to a health facility. It can't be malaria. I will just wait it out. So we wanted to see, does it change the health-seeking behaviors of the mothers towards their children? And it actually did not affect that at all. The mothers, when their children fell sick, they still promptly took them to hospital for proper diagnosis and treatment. And the last reason it was being piloted was to find out, will it affect the uptake of other prevention methods? Remember earlier I had said there is no method that is 100%. So the worry was, if a child gets a vaccine, would the mother say then there is no point of the child sleeping under a mosquito net? Yeah. Would the mother say there is no point of taking other, malaria prevention interventions available? And actually that also did not happen.
Kenya is among the 3 countries, and we already have maybe some doses with us. How many do we have? What's the rollout plan? Are we also starting with the pilot counties? When do we look at moving to other counties that are affected, especially at the coastal region?
Now, first, when WHO made this recommendation that the vaccine, the malaria vaccine can be used widely amongst children living in malaria risk zones, it was what we may call an early announcement. The pilot was meant to continue up to the year 2023. Then we can see what the outcomes would be and make a decision. WHO would see and make a decision. However, it was hugely successful. So WHO recommended that now we should not take the pilot as long as we had planned. We have the results that we wanted, and we can recommend it for wide use. So number one about our roll-up is where the pilot was happening, it's not going to stop. The children there will continue being immunized or being vaccinated against malaria. At least we have enough doses right now up to the year 2023. However, for any vaccine to be introduced, this was a pilot. Now we need to formally introduce this vaccine to the country, number one, and to the routine immunization, the one we've said that the children get. In Kenya, we have an institution called the Kenya National Immunizations Technical Advisory Group, KENITAG, and which is a panel. It's like a panel of experts in vaccines and immunizations, from institutions of higher academic learning from WHO, from experts in the field, also incorporating Ministry of Health experts. These institutions will sit down and be able to make a decision on the scale-up plan for the country as a whole. As I've said, malaria transmission doesn't occur uniformly in this country. So there'll have to be made a decision based, number one, on the resources that we have, the vaccines available globally. Like you've seen with the COVID vaccine, you might have a will to do something, but the vaccines are not available globally to be able to fulfill, the need that is there. So we need to create demand that we can be able to fulfill. And also, the human resource, having health workers being able to be trained to administer this vaccine, being able to recommend it to their mothers, and most importantly, the community. When there is a lot of excitement about such a vaccine, number one, there is a misconception of why it's only this group that are getting it and not everybody else who are not at risk. That needs to be addressed. But also there are usually the few vaccine skeptics that also we need to work with. I think the last point I'd like to highlight also is as we plan the rollout, we also need to think about maintaining. We say the resources are limited in any setting. We also need to still maintain and scale up the other prevention interventions. The reason I say that is that this vaccine, we are giving it at children from 6 months to, as they grow to 2 years. So you still have this other big population that will still remain unvaccinated. And we still need to maintain, sustain these other prevention, malaria prevention interventions until we have a critical population of people who have been immunized, where we can say now we can feel the full impact of the vaccine. Okay, thank you so much, Dr. George Githuka. We have to wrap it up. I thank you for being part of this informative show on malaria prevention, and we wish you at the Division of Malaria Control all the best as you look forward to rolling it out. Thank you. Thank you so much. We bring this show to an end. Thank you for watching. My name is Purity Musel. Do enjoy the rest of our programming, and God bless.